He's a clinical professor at the Wazoo College of Medicine and serves as the nephrology services lead at Providence Sacred Heart Medical Center in Spokane. He received his medical school education at the University of California, Irvine, and completed his internship and residency through the Providence Internal Medicine Spokane program, followed by nephrology fellowship at the University of Washington. He's practiced all aspects of general and transplant nephrology in Spokane and has made medical education a parallel part of his practice. He enjoys teaching med students along with internal medicine residents. So I will hand it over to you, Dr. Mroch. Thanks for being here.
Thank you for the kind introduction. I guess first and foremost, can you hear me okay?
We sure can, and we can see your
Awesome.
slides.
You do see them?
Yeah.
All right. Well, thank you everybody for the number one, thank you to the planning committee for the invitation to speak with you today. And to the rest of you, thanks for hanging out for a nephrology discussion in the middle of the afternoon on a Saturday. My topic today is I was asked to speak on some form of update in nephrology, and I wanted to come up with a topic that I thought would be pertinent to every one of us as we face our patients in our varying clinics and specialties. And my presentation today is called Getting to the Heart of Kidney Disease. And this is sort of a chronic kidney disease story slam, just more than 400 words. So, first and foremost, I have no disclosures to make. Goals today are to talk about the magnitude, risks, and mechanisms for chronic kidney disease, emerging guideline-directed therapies that are becoming available, and this really important interplay between chronic kidney disease and cardiovascular disease, and discussing strategies on how we might consider implementing these therapies. And so the theme of this presentation is sort of starting where we've been and where we are headed in terms of therapeutic options. Um, Briefly, chronic kidney disease remains a major public health concern. There's some 850 million patients, if not more, worldwide. And with the survivability of chronic kidney disease and leading into its inherent complications that we'll talk about, it's anticipated that CKD will become the fifth leading cause of death within the next little more than a decade. In the US, there are close to 40 million patients with chronic kidney disease, which we'll talk about. And again, within this patient population, there's a very substantial mortality rate associated with that. So chronic kidney disease it can be considered a very major cardiac risk factor. And as per the adage goes, CKD dies from CAD. And sorry for the busy slide here, but this was a study done out of Alberta, Canada, about 10 years ago. And what this really illustrates here is the red line being this major cardiac equivalent line, which is a GFR of under 60 as opposed to a GFR of greater than 60. And so the question was asked, if patients have less severe kidney disease, what's the most common cause of their mortality? And in this study of 85,000 deaths in Alberta, the majority died from cancer if they had generally good kidney function. But if the GFR was less than 60, so this leading to stage 3A, 3B, and stage 4 CKD, it's cardiovascular disease that really has this uptick throughout that. And if we look at the cardiovascular disease population down here at the bottom panel, what is it that's leading up to this? And it's predominantly ischemic heart disease that we're talking about. So valvular heart disease, cerebrovascular accidents, arrhythmias, much less so than heart failure itself. And certainly there's a lot of discussion now about the varying degrees of heart failure, with and without preservation of ejection fraction and so forth. So cardiovascular disease, again, is very prevalent in the chronic kidney disease patient population. And if we look at the group of patients without kidney disease, there's a risk for stroke, heart failure, and acute myocardial infarctions But if we go into the patient population with chronic kidney disease, there's not a real large change in cerebrovascular disease, but certainly heart failure has a 2.5-fold increase, as does the incidence of acute MIs. And so within these patient populations, we're not just following their GFR and so forth. We're also watching very closely for the cardiovascular complications that are so common in this patient population. And why is that? We know the traditional cardiovascular risk factors, such as hypertension, dyslipidemia, diabetes, smoking, and so forth, inactivity, the things that we counsel our patients on a daily basis. But in the setting of chronic kidney disease, also keep in mind that there are some unique non-traditional risk factors, such as anemia stemming from either iron deficiency or hypoerythropoiesis, states of volume overload, abnormal mineral metabolism, so secondary hyperparathyroidism and inability to manage a phosphate load. And then this concept of albuminuria, which we'll go into a little bit more in terms of an identifiable risk factor that we can measure and we can also follow therapeutically. So for the rest of the presentation, I'd kind of like to bring attention to this familiar presentation of a patient. So this is a 64-year-old gentleman with a prior history of biopsy-proven IgA nephropathy, type 2 diabetes diagnosed in the past 5 years. And then in terms of his labs are showing GFR of 47, so that's going to fall into the 3A chronic kidney disease category. And he has a significant amount of albuminuria. And so this is going to be this A3, and I'll kind of go over the definitions of these. But he's hypertensive, his BMI is up, his A1C is not to goal, and he just struggles with lifestyle. He's a non-smoker. So how do we treat this patient, and where have we been in the past, and what should we do moving forward? Well, first and foremost, he has this history of IgA nephropathy, and he has this history of diabetes. Very briefly, and I don't want to spend too much time on glomerular disease, but diabetes is by far the most common cause of glomerular disease that we deal with. IgA nephropathy worldwide is the most common nephritic syndrome. And so the idea being here, when we talk about nephrotic syndromes, we're really talking about disorders of the podocytes. So these are the cells that live on the outside of the glomerular capillaries, as opposed to nephritic syndromes that are diseases that are affecting the vascular endothelium. So it's a more of an internal inflammatory process of blood vessels that leads to hematuria. So diabetic glomerulopathy has many faces to it, and as it progresses from a normal glomerulus here, which has these purple dots, these nuclei are mesangial cells that are pretty normally distributed, and we see these well-preserved wispy capillary loops throughout. And insofar as what this patient would look like, they would have a normal GFR. They should have no evidence of microalbuminuria in their urine. If the patient presents with microalbuminuria in the right context, so a history of type 2 diabetes, there's this mesangial expansion that happens. These advanced glycosylation end products start to deposit within the mesangium, and microalbuminuria will start to develop because of damage to these glomerular capillaries. And then it just gets worse from there. There can be more deposition of advanced glycosylation end products, leading up to the point where these patients can be frankly nephrotic and have macroalbuminuria. And this would be the instance of these infamous Kimmel-Steele-Wilson nodules that are seen here, and then this progressing on as far as it could go into glomerulosclerosis. So when you see patients in the office and they have microalbuminuria, there is something wrong with the glomeruli. If they have macroalbuminuria, there's something very wrong with the glomeruli. And the idea being here that some of this is reversible if it's microalbuminuric. Once we get out to this stage, not so much. Now, when I started practice in 1998, there were 265,000 patients nationwide who were dialysis dependent. That number has now reached 800,000 as of 2019. And it is a very, very high risk population in terms of all cause and cardiovascular mortality. And a couple of the parameters that we follow as nephrologists, or hopefully as internists, um, albuminuria is a significant increased risk for mortality in the setting of chronic kidney disease. If you impair the GFR, it's even more so. And if you combine the two, where albuminuria and a reduced GFR are present, there's almost a 12-fold increase in cardiovascular mortal events within that population. So getting back to what we're going to do for our patients, I graduated from medical school in 1993, and this was kind of this pivotal paper that came out where angiotensin converting enzyme use was done in diabetic nephropathy, looking at trying to reduce the doubling of serum creatinine or looking at death or dialysis events within the same population. And thanks here to the Brazilian pit viper, the first ACE inhibitor, captopril, came out and demonstrated a fairly substantial reduction in risk in patients placed on ACE inhibitors. So this sort of led to the ongoing saga of inhibition of the RAS system. And by about the year 2000, losartan and irbesartan, so some of the angiotensin receptor blockers, were available and equally demonstrated this risk reduction by being on these medications in the setting of type 2 diabetes mellitus. But that being said, there was still substantial residual risk with either of these medications. So, stemming from this, attention started being paid to interventions that would involve lifestyle. So there was tight glycemic control, initiation of statins, controlling blood pressure better, diet, exercise, tobacco cessation. And the STENO2 trial, which was done shortly, a little bit after the ACE-ARB demonstrations, was done in Denmark. There, again, it was a small number of patients, but they were followed for 160 patients, followed for 21 years. And over this time, with very intensive therapy being paid to all risk factors, there was this significant reduction in cardiovascular events. And so it's sort of the therapeutic milieu at this time was mainly RAS inhibition and aggressive lifestyle modification. And so for our patient at that time, a guideline-directed therapy would be an ACE inhibitor or possibly an ARB, controlling the lipids, low-dose aspirin, and some form of way of dealing with the type 2 diabetes, whether that included insulin or not. So the decades-long gold standard was glucose control, RAS inhibition, blood pressure control, and lifestyle modification. And so moving forward, what problem are we still trying to solve? And that is the fact that there are still over 500 million patients worldwide living with diabetes. 95% of these individuals have type 2 diabetes, 5% type 1 diabetes. And whether it's type 1 or type 2, there's still 34 or 40% of these patients are going to progress to some degree of chronic kidney disease. And the deleterious problem with this is as chronic kidney disease progresses, we always tend to worry about patients having to start dialysis at some point in time. But as we look at the patient populations at risk, indeed, 10% of these patients progress to dialysis dependency, while the other 90% die from a cardiovascular event before dialysis ever becomes necessary. So the die-off rate from cardiovascular complications in the setting of chronic kidney disease is tremendous. This is sort of an older study now from over 20 years ago, done through the Kaiser Permanente system, but there were over 1 million lives evaluated in their electronic database. And you can see here that as stages of chronic kidney disease deteriorated, you can see this tremendous uptick in cardiovascular events starting at stage 3A chronic kidney disease. And the fact that this change happened between 30 and 44 mLs per minute versus the 15 to 29. This is the stage, this was originally called stage 3 chronic kidney disease. And it's because of this data in large that research started being paid closer attention with respect to um, the differences between these two groups. So they got parsed out as 3A and 3B. Now, for those who succumb to ESRD, so the 1 out of 10 patients in that cohort, once dialysis starts, that's still unfortunately not the end of the story because as we struggle with blood pressure, management of their extracellular volume space, we deal with left ventricular hypertrophy, calcification of blood vessels, and things like intradialytic hypotension. This whole milieu still very much favors, fibrosis of the myocardium, arrhythmia development, and sudden cardiac death. So even starting with on dialysis, patients are still at exceedingly high risk for cardiovascular events. And so not to belabor too many of the um, metabolic and basic science aspects to this, but if we look at why chronic kidney disease, especially in the setting of diabetes, likes to progress, it's because the metabolic milieu with high glycemic levels leads to these advanced glycosylation end products being produced, increase in reactive oxygen species. And from a hemodynamic standpoint, the RAS system and the endothelin systems are upregulated. And some of the lesser appreciated aspects of this are that these events are very pro-inflammatory, they're very pro-fibrotic, they're very pro-apoptotic. And so there's a lot of cellular damage being done as this process continues. And even more so, there, which we'll go over in a moment, there's this overactivation of the mineralocorticoid receptor activity. And so again, this becomes a feed forward cycle where we have more reactive oxygen species and so forth being developed. And the net effect with this entire process is that this leads to glomerulosclerosis. So not only are the glomeruli being scarred, but there's a lot of destruction of the tubulointerstitium with fibrosis and inflammatory changes. So in 1993, when the Captopril study came out, what was the patient population looking like at that time? And this study, it was kind of an interesting study out of Nature Cardiovascular Research, where the phenotypic profile of patients with cardiometabolic and renal conditions were looked at through the NHANES data. And if you just appreciate the clustering here, that in the 1990s, what we were mainly dealing with were patients who were dyslipidemic and hypertensive. And during the last 30 years, with the focus on dyslipidemia, hypertension, and glycemic control, there's been this tremendous reduction in the number of uncontrolled dyslipidemics and hopefully uncontrolled hypertension. But what that has shifted toward is the light blue here, which is a greater number of patients with chronic kidney disease, i.e., lower GFR, and obesity has gone up about fourfold during that same time. So now we're dealing more with obesity, dysglycemia, and worsening chronic kidney disease. So what do we do about this patient population and what are the barriers to providing the care that they need? And before we can prevent, preserve, or treat chronic kidney disease, we really need a diagnosis. So how do we come about doing that? And it's actually, from our world, very straightforward. We need either a serum creatinine level or a cystatin C level for kidney function. And then we need to know the albuminuria status to describe the degree of kidney damage, right? So microalbuminuria, less damaging so than macroalbuminuria. So there's a program or a registry through UCLA and Providence. There's approximately 3 or 4 million lives involved in that data set. But between 2006 and 2017, there were over 600,000 patients identified with chronic kidney disease. And if we just simply look at what are we doing for these patients and how are we monitoring them and how are we diagnosing them, we see here that uh, well over 90% of patients in this cohort of 600,000 had no urinary uh, protein measurement whatsoever. So no urine protein creatinine ratio, no urine albumin creatinine ratio checked. So here's a real missed opportunity as far as what could have potentially been done for this patient population. And again, this is data from 2006 to 2017. So what was the uptake of ACE inhibitors or ARBs throughout these moments in time? And you can see that, less than 10% of patients were on ACE inhibitors or ARBs, which um, we would hope to improve upon. But equally so, if we look at potential nephrotoxins, so proton pump inhibitors are a risk for interstitial nephritis. NSAIDs can cause glomerular disease. They can cause glomerular hemodynamic changes. They can cause interstitial nephritis. There's almost a greater use of PPIs and NSAIDs than ACEs and ARBs within that patient population. So more recently, studies looking at the numbers of people who are aware of their chronic kidney disease condition, only about 10 to 20% of patients who have chronic kidney disease are aware of it. And if we take that patient population who is aware of it, how well are we doing in terms of screening and monitoring and treatment? And we can at least see here now, as of 2024, proteinuria monitoring is improving. Blood pressure control still stands to improve. A1C control is improving. RAS inhibitor use continues to improve. And uptake of SGLT2 inhibitors and other more contemporary treatment options, still not so much. So in terms of screening for chronic kidney disease, um, this heat map that's produced by KDIGO. So this is the kidney disease or kidney disease improvement and global outcomes group. And basically, this heat map describes this relationship between varying stages of GFR and varying degrees of albuminuria. And what this map tells us, and the numbers here really have to do with the recommended number of times these patients should be seen per year. But equally so, this heat map really describes the degree of risk for which our patients are at. And as patients progress through lower stages of GFR and increasing degrees of micro to macroalbuminuria, there's a notable increase in kidney failure, cardiovascular events, and death. So this is a very, very powerful stratification strategy for us to use in trying to determine where patients are at in the course of their disease. Now, this slide, the spirit here is this comes from a hypothetical study done, but this is from 2003, where the whole concept of what's happening to a patient if they have a decline in their GFR. So here, this is 5 mLs per minute per year versus 1 ml per minute per year. And what is it we're trying to treat? And a big part of what you'll see the nephrology literature leaning toward is trying to reduce this slope. So for example, if you have somebody who's losing 5 mLs per year, and you can introduce an intervention and change them more toward a 1 ml per year, you're hopefully gaining a lot of time by which the patients don't have to worry about developing end-stage kidney disease. And through the course of this, reducing cardiovascular events. So how do we do that? Well, there was a simple drug introduced for diabetes around 2010. I guess it was 2012 with dapagliflozin came onto the market. Dapagliflozin is actually a derivative of florazin, which was a compound isolated from apple tree bark back in 1835. And just to put that in context, in 1835, Charles Darwin was floating around on the Beagle somewhere in South America on his way toward the Galapagos Islands. So That's the time at which this molecule was identified. And some 150 years later, the first SGLT2 inhibitor was derived from that. And it was initially started out as an add-on glycemic medication, which does improve A1C by about 0.5%. The cardiology world here in green with their cardiovascular trials noted that there was a significant decrease in heart failure events in patients on SGLT2 inhibitors. And then most nephrology studies sort of piggyback onto other people's trials. And so within this group, it was noted that there was an improvement in GFR, reduction in albuminuria when they looked at the subgroup analysis, which led to the big trials from 2019, 2020, and 2022 which were the canagliflozin or the Credence trial, dapagliflozin, and empagliflozin, looking at patient groups with varying degrees in GFR and varying degrees of proteinuria. And so the reason for these studies was to try and cover more of the heap map, which was successfully done. And these studies were notably positive. At the moment, there's a trial going on in Europe called the DAPA-HD trial, which is looking at the use of SGLT2 inhibitors in dialysis patients. Now, no nephrology talk is complete without at least mentioning the macula densa at least once. So here, if we look at this diabetic nephron, the diabetic nephron is going to hyperfilter because there are an incredible number of osmoles being delivered to the proximal tubule. There's hyperabsorption of sodium and glucose through these SGLT2 channels. And the more distal nephron is getting robbed of osmoles, which leads to activation of the RAS system. And through that mechanism, the afferent arteriole dilates, which increases the intraglomerular pressure. And this is what leads to diabetic hyperfiltration. And up until more recent years, the only real way we had to mitigate that was glycemic control or dilating the efferent arteriole with ACEs and ARBs. And so along came the SGLT2 inhibitors. So this is the diabetic nephron on an SGLT2 inhibitor, and the avoidance of reabsorption of sodium and glucose in the proximal tubule leads to reconstitution of osmoles in the distal tubule. It turns off the RAS system, and this afferent arteriole vasoconstricts, and diabetic hyperfiltration is reduced. So without going into too many other details, these SGLT2 inhibitor medications are amazing to me because they're almost like a Swiss Army knife, but they act as natriuretics, they act as osmotic diuretics, they decrease tubular oxygen consumption. In the heart, they help with decreased left ventricular wall stress. From a hormonal standpoint, these medications increase red blood cell mass, and so there's this increase in erythropoiesis. And even within our own clinic, we have a dramatic reduction in erythropoietin that we're having to administer to patients with chronic kidney disease. So in terms of where these medicines have helped us, empagliflozin, remember I was trying to talk about the improving the slope of decline. So here placebo was at this rate of decline and the empagliflozin was flattening out. Similarly, canagliflozin showed a reduction in rate of change of GFR. And the idea being here that if you can keep this patient's GFR at that level for longer, they can avoid not only the prospect of dialysis, but also hopefully mitigate cardiovascular events. So this trilogy of SGLT2 inhibitor use in CKD has been tremendous. And across the board, these agents have helped to mitigate decline in GFR, risk for developing chronic kidney disease, or excuse me, ESRD, and also decreasing death from cardiovascular causes. So as it stands, SGLT2 inhibitors, they decrease albuminuria, they decrease cardiovascular events, they decrease major adverse kidney events, and have sort of become a a real cornerstone now for how we're treating patients with chronic kidney disease. So by 2023, guideline-directed medical therapy included RAS inhibition and now adding SGLT2 inhibitors with pretty compelling data that it's the right thing to do. Now, switching gears a little bit, if we look at the renal parenchyma and the renal interstitium, the renal interstitium is very immunologically active neighborhood. And with the increase in mineralocorticoid activity, there are increases in all these inflammatory mediators that, again, we're going to promote the worsening of CKD. And so the theory came out that if we could reduce mineralocorticoid activity more effectively, what effect would that have in the setting of chronic kidney disease? Now, spironolactone is sort of our hallmark mineralocorticoid receptor antagonist. There is a newer medication among many others called finerenone that is much more specific for the mineralocorticoid receptor that doesn't have all of the additional noise from the other sex hormone receptors and glucocorticoid receptors. So it's a very specific medication for blocking that receptor. And this led to the renal outcomes trials and the cardiovascular outcomes trials, one called Fidelio, one called Figaro. And this is looking at finerenone versus placebo. And albeit the hazards ratio were not tremendous, there was still close to a 20% reduction in events with patients on finerenone. And so as an adjunct to that, it has sort of become our next go-to medication in terms of trying to help mitigate progression of chronic kidney disease. There's a tremendous amount of emerging literature in the cardiovascular literature with respect to heart failure improvement and so forth, and also looking at cardiovascular deaths. And across the board for major adverse kidney events, major adverse cardiovascular events, finerenone is certainly favored. And now we're emerging on this as of this summer, the integration of therapies, which has yet to be better defined. But there was the confidence trial that came out in the New England Journal in June of this year, and it was looking at empagliflozin, SGLT2 inhibitor versus finerenone, and the ability to reduce the urinary albumin content. Each of these in isolation versus combination of SGLT2 inhibitor and finerenone. And here you can see there's this dramatic reduction in urinary albumin. And so the next step is going to be how does this translate to outcomes? And that information is not yet available. So I would make the argument now that we have our guideline-directed therapy to include not only the RAS inhibition, but finerenone and an SGLT2 inhibitor, along with the usual lifestyle modifications. And then dovetailing into what Dr. Kim was talking about with respect to GLP-1 medications, when GLP-1 medications are used, also keep in mind that there are some very significant cellular events happening beyond the usual, phenotypic results that we look for. But if we look here on the left side, here is a dysfunctional diabetic glomerulus with podocyte effacement, increased inflammatory milieu, increased advanced glycosylation and product deposition, and basically just a glomerulus that's trying to work its way toward glomerulosclerosis. Theoretically, with incretin-based therapies, there could be decreased mesangial expansion, decreased activity of immune cells, reconstitution of the podocytes. And as a result of that, the GLP-1 medications help to reduce reactive oxygen species through this heme oxygenase pathway. There's decreased apoptotic signaling and decreased production of cytokines and so forth. So these incretins come to us thanks to the southwestern Gila monster. So the original, as I recall, the original GLP-1 agonist was derived from the venom of the southwestern Gila monster. So, in terms of GLP-1 medications versus just insulin itself, so this is a study from 2018 looking at dulaglutide versus glargine in patients with moderate to severe CKD. This is looking at preservation of GFR. The GLP-1 medications were substantially better than glycemic control alone. And so this became an area of interest in terms of trying to preserve GFR and reduce the slope in terms of GFR decline, which then led to the SUSTAIN 6 and PIONEER trials, which were looking at semaglutide and the ability of this medication to um, preserve GFR. And again, we see semaglutide here in the dark blue. The slope compared to placebo is considerably improved with preservation of GFR through the time of the study. So um, the GLP-1 drugs have definitely shown on their own to be beneficial, which then led to the FLOW trial, which came out toward the end of 2024. And this study was stopped early because of clear positive efficacy. But this was looking at semaglutide in the setting of type 2 diabetes mellitus and its ability to preserve GFR. And again, in the semaglutide group, there's this a reduction in the slope of GFR decline over this 4-year period. And in terms of cardiovascular major outcomes, there was a reduction in those as well. And so this study was actually stopped early because of efficacy, and again has sort of become a cornerstone for how we're now trying to address patients with both diabetic and non-diabetic kidney disease. So guideline-directed therapy now would not only be RAS inhibition, but introduction of the SGLT2 inhibitor finerenone and adding on the GLP-1 receptor agonist. So getting back to how well we're doing with this now as of 2021 through 2024, and this is very new data. This is the same Cure CKD registry out of the UCLA Providence database. Throughout this time, use of ACE and ARBs has dramatically improved. Finerenone use remains quite flat. SGLT2 inhibitors in the last 2 years has at least doubled. And as far as the GLP-1 receptor agonists, these are certainly gaining more of a toehold in terms of treatment of patients with chronic kidney disease, diabetes, and so forth. But the data is certainly emerging that tells us that these are things that we should be doing for our patients. So in terms of this therapeutic landscape, if we go back to the 1990s through 2000, this was the era of ACE inhibitors, angiotensin receptor blockers, and then came this time what I call the therapeutic doldrums, where we kind of focused on lifestyle modification and glycemic control and a lot of agents that did not show much promise or showed negative results. Up to more recently, where we have these studies in red, which are the SGLT2 trials that we talked about. The green are these finerenone trials. The yellow is an endothelin trial that was done in isolation and now has translated into this one called the Zenith trial, where it's an endothelin receptor antagonist coupled with an SGLT2 inhibitor. And then up and coming, even through our own clinic, we have a lot of patients getting enrolled in that's called the EASY trial. But the kind of teal colored studies here are looking at these aldosterone synthase inhibitors. So perhaps we can even get away from having to block the mineralocorticoid receptor if these drugs show efficacy. So there is a tremendous therapeutic armamentarium that's developing in our ability to have a very positive impact on patients with both diabetic and non-diabetic chronic kidney disease. The holistic approach now to diabetes still includes RAS inhibition for whether you're type 1 or type 2, but for type 2 diabetics, starting an SGLT2 inhibitor early and metformin is still a very first line therapy that we would recommend. And then based on other comorbidities, either adding on a mineralocorticoid receptor antagonist, or adding a GLP-1 receptor agonist. And so our direction and how to treat and screen for this is changing. So if you look at the ABCDEs of CKD and cardiovascular disease, we have the traditional blood pressure, cholesterol, and diabetes that we want to be aware of and how to monitor these. But also don't forget about the eGFR, and don't forget about the albuminuria in trying to better define where our patients are at in the course of their disease. And to steal from the neurologists, where they talk about, time is neurons, I would argue that time is also nephron mass, and that we don't want to lose time in patients who have hyperfiltration. And so it's well worth introducing many of these pillar medications, possibly even all in short order rather than waiting for longer periods of time. So take-home points, ACE inhibitor, SGLT2 inhibitor, or any form of RAS inhibition are probably first-line GDMT for patients with CKD with or without diabetes. Give great consideration to starting a GLP-1 or something like finerenone in the proper setting, especially if they have albuminuria or increased cardiovascular risk. Semaglutide is the first GLP receptor agonist that's shown to improve kidney outcomes as well as survival benefits in that patient population. And I just really would like to stress the fact that CKD detection awareness and access to care and implementation of these strategies is really going to be needed to try and help provide our patients these, kidney, heart, and life-saving medications. So as per the large learning language models here, here we have the kidney and the heart, and it's being guarded by the Brazilian pit viper, the southwestern Gila monster, and the apple tree. And with that in mind, um, thank you for your attention today, and may you all go forth and consider becoming flosinators, glipinators, and finerenators. I made that one up. So all in the effort to save hearts, kidneys, and lungs.
Thank you
I'll be
so
happy to
much.
I'll be happy to take any questions.
Yeah, and we have some for you. Thank you so much for that talk. I know many of us will likely be downloading your slides and using some of those great diagrams and illustrations you had in there. Thank you. The first question is whether there is data showing whether dapagliflozin or empagliflozin is superior. Do you have a preference in one over the other, noting copays for both are highly expensive for many patients?
So in terms, no, I don't have a preference. There is more data out there yet, but there's basically, I would say, an equivalence to using dapagliflozin or empagliflozin. And the prices are coming down. I know they're still high. They're not as bad as they were 3 years ago. And I think dapagliflozin is supposed to be coming, or is supposed to be coming generic. I think the end of this year or the beginning of next year. So we'll see where that goes. And of course, that remains the problem with all of these therapies. Finerenone is not inexpensive. The GLP-1 drugs are not inexpensive, and the SGLT2s neither, but getting better.
Great. Next question, discuss CKD versus age-related kidney function decline and how this affects management.
So senescent decline in GFR, we expect to see, and it's something where we don't expect to see albuminuria associated with that. And if after age 50, having a decrease in, 1 ml per year, 1 ml per minute per year in GFR is expected, provided the patient starts out with a normal degree of renal function. As they age, that becomes not so much of a problem, but if that is superimposed on the underlying chronic kidney disease from hypertension, diabetes, and these other comorbidities, then certainly treating is going to help offset age-related changes because that's one thing we can't change with these therapies is senescence. So I hope that answers your question.
Yeah. And the next question is what percent of patients on optimal CKD therapy with good volume control would clinically express CHF if the volume control loosened?
If the CKD is well controlled and the whole hormonal, the neurohormonal and metabolic milieu is favoring diuresis and natriuresis and so forth, the heart failure is much, much easier to control, but as we then progress into things like cardiorenal syndrome, where you kind of have the worst of both worlds because usually if the kidneys aren't doing so well, the heart can compensate. If the heart's not doing so well, the kidneys can compensate. But if both of them are in peril, those are the group that become very challenging to treat. But I will say that um, the physiologic benefits of being on SGLT2 inhibitors is just amazing to me because not only do you have natriuresis and diuresis, you have improvement in hemoglobin. There's decreased myocardial oxygen consumption, decreased renal oxygen consumption, and heart failure activity just really responds well to that. So I hope that helps answer the question.
Yeah, it certainly does. Well, thank you so much again, Dr. Mroch.